Good morning, everyone. We'll start in about 3 minutes. So please, well, it looks like everybody is seated. So we'll start in a couple minutes. All right. Good morning, everyone. It's so wonderful to see you all here today for our LGBTQ plus health in Hennepin County data resiliency and action forum. So it's wonderful to see you all. I'm Jonathan Hanft. I'm the Ryan White program manager in public health. I use he, him pronouns. Just a little bit of housekeeping. So please help yourself throughout the morning to refreshments over there. The restrooms are right outside the door to the right. There are, hopefully you picked up an agenda, and I think there are some on the table as well. So I will be emceeing today's program, and we will begin, and I'd like to welcome the chair of the Hennepin County Board of Commissioners, Commissioner Irene Fernando, for a welcome. Thank you, Commissioner.
Good morning, everyone. I am Commissioner Irene Fernando, but you can call me Commish. I use she, her pronouns, and it really is an honor to get to be here today. I was elected in 2018, and so in 2019, I became the youngest woman to ever serve on the Hennepin County Board, the first Filipino American elected in the state of Minnesota, and as of last year, I am the first board chair of color in Hennepin's 172-year history. Thank you. I ran for office and I govern, and I'm partnering with you for very, very specific reasons. First and foremost, to advocate for those who are marginalized or structurally disenfranchised. Second is to partner across all layers of government to advance our most complex issues. And last, but certainly not least, is so that all people, particularly those who've been underrepresented or underserved, can see themselves in the story of leadership in politics. Good government and good governance is not something distant from our experience. It is something that is essential to the health and well-being of every single person, regardless of who they love, their country of origin, or the documents that they may have. Good government should be about ensuring that everyone has what they need to lead full and vibrant lives, safe and genuine in their belonging, authentic and full in their personhood. And so today's session is such an essential aspect of what the county is trying to do. What we've succeeded in doing, but the long journey still ahead of us. It is thanks to your challenges, the ways in which you challenge the system and challenge norms, the way in which you ask questions and engage in inquiry, the feedback, ideas, and curiosities that you might have translate into strong questions and then must translate into even better data. It is through the compassionate and methodical collecting of inclusive and full personhood data that the county will be able to identify the areas that we must be pursuing. Areas that other jurisdictions or other states might not yet have the courage to pursue. And so my main function for being here today is to thank you for the courage and compassion that you engage in your work every single day, sometimes without notice, and perhaps sometimes without thanks. And so on behalf of the county board, I wholeheartedly thank you for the ways in which you are advocating for our residents today and for the ones we haven't met yet. And of course, we are not here to compare to other states and to other experiences, but particularly over the last couple of years with respect to gender affirming care and to protect all trans people, but especially our trans youth. And so I'm here to thank you, to welcome you to this, and look forward to the few minutes I'll get to share with you today. Thank you.
Thank you so much, Commissioner. Just a note on the next piece of this for those of you online, and welcome to those of you who are online. We're going to show a video, and we're not going to be able to show it online, but we will put the link to it in the Q&A box, and we will also send it out after this program. We're honored to have a video from the U.S. Department of Health and Human Services Assistant Secretary for Health, Admiral Rachel Levine, for some opening remarks. Admiral Levine serves as the 17th Assistant Secretary for Health for the U.S. Department of Health and Human Services and is the head of the U.S. Public Health Service Commission Corps. She fights every day to improve the health and well-being of all Americans. She's working to ensure health equity is front and center to build a stronger foundation for a healthier future, one in which all people and places in our nation can thrive. Admiral Levine's storied career, first as a pediatrician and adolescent health medicine specialist in academic medicine, focused on the intersection between mental and physical health, treating children, adolescents, and young adults. Then as Pennsylvania's Physician General, and later as Pennsylvania's Secretary of Health, she addressed COVID-19, the opioid crisis, behavioral health, and other public health challenges. Please play the video.
Hello, I am Admiral Rachel Levine, she, her pronouns, and I am proud to serve as the Assistant Secretary for Health at the United States Department of Health and Human Services and the head of the United States Public Health Service Commission Corps. I am honored to be the first openly transgender Assistant Secretary for Health, Senate-confirmed appointee to federal office, and four-star officer across the uniformed services. Achieving health equity requires valuing everyone. We all have a role to play in making progress without leaving anyone behind. All of our policies are about making people healthy, and not just some people. All people and places across our nation should be thriving. My office is leading key policy initiatives to advance health and well-being for LGBTQI+ people broadly and transgender people specifically. We are working to end the HIV epidemic in the United States with a specific focus on health disparities. We are working to safeguard LGBTQI+ youth from the harms of conversion therapy. And we are working to promote data equity for LGBTQI+ people in healthcare settings so that we can appropriately address health disparities and work toward health equity. Collecting population-level sexual orientation and gender identity, or SOGI data, is key to meeting the needs of LGBTQI+ people. Today, it is a best practice in data science to incorporate SOGI data into data instruments. This leads us to apply resources where they are most needed. We need to understand health disparities to do that, and we need data to tell us where those disparities exist. But not all state and federal data instruments include demographic questions on sexual orientation and gender identity. This can lead to underrepresentation, incomplete pictures of communities, and ultimately inadequate medical care. HHS is leading efforts to address this through our SOGI Data Action Plan, which seeks to make SOGI data the norm in public health and human services. We are already seeing incredible success. The CDC added SOGI measures to HIV, STI, and MPOX case reports. The Centers for Medicare and Medicaid Services added SOGI measures to the healthcare.gov enrollment application and the Medicare Part C and D enrollment applications. The Substance Abuse and Mental Health Services Administration, or SAMHSA, added gender identity questions to the National Survey on Drug Use and Health. We continue to advance data equity every day. The HHS Healthy People 2030 report, which is in my portfolio, includes several important national public health goals specific to the LGBTQI+ community. And it is worth naming them to get a sense of how acute and pervasive these health risks are. Objectives include increasing the number of national surveys that collect data on sexual orientation and gender identity, increasing the number of states and territories that use the standard module on sexual orientation and gender identity in the behavioral risk factor surveillance system, and increasing family acceptance of LGBTQI+ youth. These objectives are consistent with the medical and public health goals of saving lives and improving quality of life. HHS exists to provide scientifically supported information to those who can use it to save lives and improve public health. This part of our mission has never been more in demand or more under attack. Despite the heavy toll it has exacted, the challenge of the last few years remind us of a fundamental truth, that we need each other, that our happiness and our very survival depend upon our connections to one another and to our community. And that spirit of community is what we need now more than ever. We must call upon it again. I believe we can and must build these connections and opportunities to realize health and well-being for all. We can do this in a manner that enables us to truly support equity in engagement, access, and outcomes, and build a society in which all people and places thrive without exception. We can do better. We must do better. And with your help, we will do better. Thank you. Hello, I am Admiral Rachel Levine, she, her pronouns, and I am proud to serve as the Assistant Secretary for Health at the United States Department.
Thank you, Admiral. It's wonderful to have her join us by video. We're also honored today to have Minnesota Department of Health's Assistant Commissioner, Dr. Robson-Tura, here with us for some opening remarks. Dr. Robson-Tura serves as the Assistant Commissioner of Health at the Minnesota Department of Health. He supervises key divisions, including Health Equity Strategy and Innovation, American Indian Health, African American Health, Diversity, Equity, Inclusion, and Belonging, and the Health Equity Performance and Research section. With over 19 years of experience, he is a distinguished public health leader, researcher, and educator. Dr. Tura's research has been published in esteemed journals. With a robust background as a public health practitioner, he spearheaded the design, implementation, and evaluation of health education and community programs, overseeing substantial grants from government, private entities, and foundations. His leadership spans roles from managing country programs in international settings and refugee health initiatives in county public health and health equity at the Minnesota Department of Health. Passionate about advancing equity through systems transformation and fostering a sense of belonging in communities, he works to connect academia with public health practice. Dr. Tura holds an MA in Public Health Education, an MPH in Nutrition, and a PhD in Community and Behavioral Health from the University of Iowa. He is also a certified health education specialist. Dr. Tura emphasizes the importance of an equity lens in systemic change efforts. Please welcome Dr. Tura.
Thank you. That is a glaring introduction. Thank you so much. Thank you for having me here today. And I don't even know how I follow the two speakers that went ahead of me, the Assistant Secretary and the Commissioner. Thank you so much. And you really spoke something that is very close to my heart. And I said, I wish I met her before so that I can rewrite my address today, because system is key to me. System is what is perpetuating what we're going through. So system that is not made for us, by us, continue to perpetuate the inequities and disparities that we face based on our social identities, race, ethnicity, gender identity, sexual orientation, disability status, right? Those systems are really designed to do exactly that. And then you talked about that, and thank you for addressing that. But that I'm going to take a little bit of time today just to address issues related to data. First of all, thank you so much for inviting me. This is it. This is the space where I really wanna be. So thank you to address this important forum. So I stand before you today to address the pressing issue that really demands our attention. The vital importance of LGBTQ plus inclusive health data in Minnesota, and the critical role of this data in eliminating disparity within our community. As you all know, data is not merely a collection of number or statistics. There are people behind those percentages numbers, right? So it is a compass that is guiding us toward equity and justice. Yet for too long, our LGBTQ community has been rendered invisibility in our health data. And as a result, the health needs of this community is not fully acknowledged and addressed. So the consequence of this invisibility is profound. Without this comprehensive data, we cannot fully grasp unique challenge that our LGBTQ plus individuals are facing. We cannot identify disparities in access to care, disparities in health outcome, and also disparities in experience, treatment experience. And without this understanding, we can't really make any impactful change in our communities. This data is so powerful and needed. So I know you are all going to hear a lot about the local data, but I want to say a little bit using a national data related to the disparity that we see among our communities. The national data reveals that LGBTQ plus individuals or youth are 2 to 3 times more likely to attempt suicide and experience elevated homelessness up to 40%. Gay men are at increased risk of HIV/AIDS and sexually transmitted disease, especially with communities of color. Lesbians are less likely to access preventive cancer services and are more prone to being overweight and obese. 19% of the LGBTQ individuals report being denied care outright due to their sexual identity or sexual orientation, gender identity. 28% experience verbal harassment in medical settings, with 2% reporting subjects to physical attack in a doctor's office. How that feels? How do we feel about that as a nation when someone gets attacked in a doctor's office because of their gender identity and sexual orientation? We're not doing well as a nation. Over 28% reported postponing or avoiding medical treatment when sick or injured. And 33% acknowledge delaying or foregoing preventive healthcare measures. That's how we look like as a nation. So having such data for our state is critical for us to understand health disparities, tailoring healthcare services, allocating resources, advocating for policy change that the commissioner was talking about, the system change that is needed, reducing stigma and discrimination, and promoting health equity. So, but make no mistake, the stake could not be higher. LGBTQ individuals face many barriers when seeking healthcare, from discrimination and stigma to outright denial of care. Transgender and non-binary individuals in particular, they often confront insurmountable challenge when accessing gender-affirming care, facing rejection and encountering policies that exclude them from coverage. So the lack of LGBTQ inclusive health data perpetuates this cycle of invisibility and neglect. Without accurate information, policymakers overlook the specific need of LGBTQ community when allocating resource or designing healthcare programs. Healthcare providers may lack the training and the resource that is needed to provide culturally appropriate or culturally sensitive care, further perpetuating this inequity. So that is all kind of sad news, right? But today I'm conveying a message of hope and a commitment from our state leadership, including MDH and our legislators. Is there any legislators, elected officials in this? Thank you so much for what you do. Probably you're online. So over the last few years, MDH conducted a detailed inventory of our own data. And then after robust community engagement, we developed a data disaggregation standard so that we can properly collect SOGI data. Last year, what we call it the historic legislative year, the legislators passed a bill that helped us to move toward data disaggregation standard as a state that MDH and MMB is leading the charge. So I also convey this message of hope and a commitment from our own Hennepin County. Thank you, Commissioner, again for your leadership, and other leaders that are working with you. The county that has been leading the way for a few years now in creating inclusive data. With the effort from Hennepin County's survey, the tide is really turning, and the change is on the horizon. In Minnesota, we have the opportunity to lead the charge and toward a future where health care is truly inclusive and affirming for all. So by prioritizing LGBTQ inclusive health data, we can shine a light on the disparities that our community is struggling with. We can identify areas of improvement, target intervention, and measure progress toward health equity. We can ensure that every LGBTQ plus individuals receive the care they need and deserve, free from discrimination and stigma. But this work cannot be done alone. Cannot be done only by Hennepin County. We do need these kind of things across the state. It requires collective effort and commitment from policymakers, state leadership, state public health, county public health commissioner, community leaders, religious leaders, and community alike. It requires all of us. It demands that we come together across lines of differences and to affirm the dignity and the worth for every individual in our community. So let us rise to the challenge before us. Let us commit ourselves to the pursuit of health equity, justice, and dignity for all. Let us harness the power of data that the Assistant Secretary of Health was mentioning. The power of data that drives meaningful change and a built future where every LGBTQ plus individuals can have their lives to the fullest with access to the care and the support they need to thrive. Thank you so much.
Thank you so much, Dr. Turan, and we're very happy to have you here with us today and provide those words of hope. Just one more mention before we move on to begin our data presentation portion of this morning's program. Dr. Tura talked about the national disparities that we see among LGBTQ I+ people. And you will see some of those data locally today. And I know for many of us who are members of this community, that can be very painful. Some of us experience these disparities ourselves, and many of you work with folks to try and overcome the barriers in our system so they can live full, healthy, and productive lives. And so I just want to acknowledge, and at the same time as Dr. Tura, Commissioner Fernando, and the Assistant Secretary for Health, Admiral Levine, reminds me is that we have a lot of power in this room. And if those of you have been working on HIV and ending HIV, beginning with prevention and care throughout the decades, you know that we can rise up and make change in our world. And we know one of the things that really sticks in my mind a lot is that without ACT UP and the activism in the early days of HIV, we would not have had a COVID vaccine as quickly as we would have, which saved millions of lives. And so we do have that power and we can make that change. Before we get into the data, also, I'd like to thank and acknowledge the people, many of you are here, who served as our data forum advisory work group for this forum this morning. There are many people who you can see up here, and if you are here, please stand up. These are experts in the field of LGBTQ health research, advocacy, health and social service delivery. Yes. The Data Advisory Work Group informed the content of today's data presentation based on what they thought is important to share with the community, given the richness of the data that we have and the limitations we have for time this morning. So again, thank you to the advisory group. Now we begin with our data presentations in two parts, starting with adult LGBTQ plus data from Hennepin County SHAPE survey, followed by Hennepin County, Minnesota Student Survey Youth LGBTQ plus data after our break. And I'd like to invite our speakers up for the SHAPE data, Komal Mehrotra and Mei Ding. So please come up. Komal is the manager of the Health Evaluation and Assessment Team in Hennepin County Public Health. Her work involves overseeing the SHAPE survey, a county population-based health surveillance project. Komal also has broad experience in public health program planning, evaluation, and community health assessment. She received her master's in health sciences from Boise State University and a master's in dietetics and hospital food service from India. Mei Ding is a principal planning analyst in Hennepin County Public Health. She is one of the key team members for SHAPE project. Mei has broad experience in community health assessment, health services research, public health program planning, and evaluation. She received her training in medicine from China and in epidemiology from Canada. Please welcome Komal and Mei.
Thank you, Jonathan. Good morning, everyone. Thank you for attending the forum with us today. I am Komal Mehrotra. I use she, her pronouns. My colleague Mei Ding and I, we will be walking you through some of the data collected in SHAPE survey on Hennepin County adults. This is going to be our outline, presentation outline for today. I will first share some background information about the SHAPE project, SOGI data collection, and SHAPE 2022. Next, Mei will dive deeper into the SHAPE data about Hennepin County adults, as well as BIPOC adults. We will have time at the end for questions. First, let's give you a brief overview of the SHAPE project, SOGI data collection, and SHAPE 2022. So what is SHAPE? SHAPE is a long-standing public health project, and it stands for the survey of the health of all the population and the environment. SHAPE collects information on the health of Hennepin County residents and the factors that affect their health across a broad range of topics. It is being conducted once every 4 years and has been done 7 times since 1998. Each time, between 8,000 and 12,000 residents have generously given their time and responded to the survey. The survey is administered by Hennepin County Public Health in collaboration with many community partners. So why does SHAPE matter? SHAPE provides detailed local data about the health of Hennepin County adults. This data is helpful in understanding the social determinants of health in Hennepin County and also informs various county programs, partners, and community organizations. So what kind of data does SHAPE collect? SHAPE is a comprehensive survey that gathers data that measures health in a broad public health perspective. The data can be categorized into 5 major domains listed on this slide, in addition to the demographic data, including SOGI data. Under each of these categories, SHAPE asks questions on various topics. We consult with key stakeholders, subject matter experts, public health staff, and community members to identify the emerging data needs. In the interest of time today, we will only be covering a few of the indicators under each of these domains. This slide shows us how SOGI questions have been asked over time. As we heard from Admiral Levine's remarks today, advancing data equity every day is the key. Our SHAPE SOGI data collection has the same spirit. SHAPE first started collecting SOGI data in 1998. We consulted with our communities, local and national subject matter experts, and county staff who work very closely with residents and community partners on a regular basis. Based on the feedback we received, the SOGI questions were reconstructed to reflect the community and achieve data equity to represent the LGBTQ+ residents more completely over time. Collecting SOGI data helps us understand where the health disparities exist. In 2018, the transgender question was asked separately, but sexual orientation was asked as a single response question instead of a check all that apply question. But in 2022, the goal was to go further and collect better data for our LGBTQ+ population. This objective was achieved by expanding the gender identity question to include non-binary. Transgender was asked as a separate question, and sexual orientation identities were expanded to include lesbian or gay, bisexual or pansexual, queer or questioning. We also provided an open-ended response option so that respondents could write in their own responses. This is the actual layout of the questions from our SHAPE 2022 survey. So this slide shows us the percent of respondents who self-identified as LGBT aged 25 to 64 since 1998. We see that the percent of respondents has quadrupled since 1998, from 3% to 12% in 2022. This could be a reflection of the population changes that have occurred over time or how the respondents answered the questions. I would like to point out that we didn't include the other SOGI identities here in the trend data because of the changes in the data collection questions over time. How was SHAPE 2022 administered? SHAPE 22 was a blend of in-person and mail surveys. The survey was translated in several languages, including Somali, Spanish, and Hmong. The survey was mailed to over 40,000 randomly selected households in Hennepin County. In addition, we also hosted 50 events in collaboration with our 10 community partners, which included federally qualified health centers, food shelves, community clinics, and community organizations. SHAPE is a representative sample of Hennepin County adults aged 18 and older. It is a voluntary and anonymous survey since we don't ask any name or other identifiable information. In 2022, we were able to report on 8,591 respondents, which included responses both from the mail and the in-person survey. Next, we see who all responded to the SHAPE 2022 survey by SOGI, since this is the focus of our presentation today. For the gender identity question, which is question G1 listed on the slide here, we had 98 respondents who self-identified as non-binary. This is the minimal sample size that we use for a group that we can report on in the data book. We also had 12 respondents identified as something else for this question. For our question G2, we had 84 respondents who self-identified as transgender, and we had to make a special case to include them as a reporting category as well for the data book. Question 3, which is our sexual orientation question. Here you can see the number of respondents for each of the groups for this question. We have also included questioning as one of our reporting categories for our SHAPE data book. So here we see that a total of 1,004 respondents checked at least one of the sexual orientation or gender identity categories, and they are included in the LGBTQ plus group. I will now invite my colleague Mei Ding to walk us through the rest of the presentation.
Hi everyone, my name is Mei Ding, she and her pronoun. Glad to be in this space. And I'm going to talk about SHAPE data and LGBTQ health among all adults. As Dr. Tura reminded us, every number I'm going to show are the people behind this number, and they are our neighbor, their brother, sister, aunt, and the uncle, and just thinking about their real people. Oh, yes, LGBTQ health, LGBTQ plus health and health among all adults. And we are going to walk through, select a couple of the health indicators from each of the domain. First domain is overall health and health condition. The first indicate is the poor or fair health. We're using survey question and read as in general. Would you say your health is excellent, very good, good, fair, or poor? And those responded to check the poor or fair are classified as reporting poor or fair health. And this is the data we are going to present for every single health indicator. We are going to present data for 3 of the each identities, what the SHAPE 2028 gather. First is the gender identity, second is the transgender group, and the third is the sexual orientation. Knowing this slide is very busy, they have 9 data points. Among them is the 5 LGBTQ plus groups. It's in these 9 points, and on the other is non-LGBTQ adults. Since SHAPE is a sampling survey, so every data we list here, if we say if the differences between groups is indeed a difference or not, we need to conduct a statistical test on that. And the results of such that is kind of printed as an asterisk under that at that group label. That's indicated between groups, the statistically significant difference. It is indeed statistically significant. So that's kind of how complex of these. The table could, the data, each data slide could be looks like. And let's focus on the first indicate here. It's reporting poor or fair health. And among those transgender, 29% reporting poor or fair health. And that rates, it's double the size of those non-transgender. Another significant difference is the bisexual and the pansexual. So we do try to in summary, the overall takeaway for these slides is LGBTQ adults reporting poor, LGBTQ plus adults reporting poor or fair health at up to 2 times the rate of non-LGBTQ plus population. And this slide is just adding a little bit more. It's we also for each health indicate, we are providing a county-wide estimate and use a dotted gray line, horizontal gray line, so you can easily see what the group is about above county average and what is under. And from now, you may see there's 18%, and the data presented here is the bisexual, pansexual, 18%, queer, and it's 18% as well. And exactly the same rates, but the one group is statistically significant, the other isn't. So the reason behind that is every single statistics test have several driving kind of the critical facts contribute to that comparison. The first, the size of difference, because each of these groups is compared to the straight or heterosexual. And the size of the difference is really, really important. But in addition to that, it's the sample size as well. Although these two groups showing exactly the same differences between their group, this group, and the straight and the heterosexual, but the sample size for bisexual, pansexual is 410, where queer is 235. So it's the between group, the sample size is different, and so which make one group statistically significant, the other isn't. So you will see some cases through the kind of these slides, and that's the reason behind. We just spend a bit of time to explain that. The second indicator we are going to show is activity limitation. The reason we phrase it as activity limitation just due to the nature of how the question is asked. And it's really said limited in any activity. And this is this is often the health indicator we measure broad disability. And this is the data we show, and you see, and among all those above average are LGBTQ plus population, and the 4 of the groups is above. Each of these groups is statistically significant than other. And on top of that is 2/3 of the non-binary and 2/3 of transgender reporting activity limitation. Key takeaway is LGBTQ plus adults reporting activity limitation at up to 3 times the rate of non-LGBTQ plus adults. And you also see the rates across LGBTQ plus adults groups are various. They are not equal itself. Moving towards the next domain of the health is the mental health and the well-being. And again, we only have time to select the 2 or 3 indicate to show data here. The first measurements is the high risk of depression. It's a measure we're using the 2 survey question, which is well established screening tool called the Patient Health Questionnaire. And this is how survey question looks like. And I'm not going to let you read through for the sake of the time, but these will be included in the handout or whatever the file we're going to make available to you later. So you can read and study, have a question, check our data book technical notes, or just call us anytime. So we will explain to you how we define that. So we are not, from now on, I'm not going to read the question, not explain how the variables are defined, which you will have that information and read later. So looking at these data, you will see all 5 LGBTQ plus groups are above average. Every single statistical comparison are statistically significant. In key takeaways, LGBTQ adults reporting high risk of depression at up to 5 times the rate of non-LGBTQ adult population. And the rates across group varies significantly as well. And on top of that, it's the 40%. It's about 40% of LGBTQ adults. And reporting high-risk depression. The second is high-risk anxiety. Again, we're using 2 survey items to gather that data. And the question is really like, it's a 2 survey question as well. Look at the data, it's a very similar pattern as you see for the high risk of depression, high risk anxiety, and for all LGBTQ adults reporting much higher at up to 4 times the rates of non-LGBTQ adults. And the rates across LGBT, these 5 groups, are various. The size of disparity experience is not equal even within these groups. Next is the frequent social isolation. And the data, again, 4 of the groups of LGBTQ plus population are above county average, which is 10%. And the overall LGBTQ adults reporting a frequent social isolation at a rate 3 times the rate of non-LGBTQ plus adults. We are quickly moving to the health access domain, and which we are going to show couple health indicators as well. First is the no usual place of care. Knowing this survey question is in the online survey questionnaires available to you and will be included in the PowerPoint file we're going to share back to you. And overall, you will see the variation of these rates with several of the groups of the LGBTQ plus adult population are above county average compared to their counterparts who are non-LGBTQ adults. And there's 4 groups are statistically significant. Overall, LGBTQ adults reporting no usual place of care at about 2 times the rates of non-LGBTQ adults. Second measure is the unmet medical care needs. These measurements is pretty much asked and if they need health care during the past 12 months and among them and who experienced delayed or did not get the care. And the results, it's against many LGBTQ plus population groups reporting much higher rates, and with 2/3 population, with 2/3 of non-binary adults reporting unmet medical care needs, and so do very high for the other population. So overall, LGBTQ plus adults report unmet medical care needs at up to 3 times the rates of non-LGBTQ adults. Next is unmet medical health care needs. And it's among those needed care during the past 12 months, delayed or did not get care for the mental health care. And for these, you will see it's very, very flat across different population, and overall, unmet medical health care is high across boards, and with more than half county population reporting unmet medical care needs. And this is true for non-LGBTQ plus adults, as well as true for LGBTQ plus population. The next domain is the health lifestyle and the risk behavior, and it's including substance use. We are selecting 2 measurements from substance use to share data today. First is the current marijuana use, which is including prescription medication use as well as the other reason. it's measured as the past 30 days. And overall, you will see every single LGBTQ plus population groups are above county average, and each statistic compare between groups are statistically significant. And 42% non-binary reporting current use, 37 and for the other, and the lesbian and the gay is 31%. And overall, LGBTQ adults population reporting current marijuana use at up to 3 times the rate of the non-LGBTQ adults. And the rates vary across LGBT groups as well. The second is the problem due to substance use. It's really asked at the family unit. So the observation of this question is for the family. And it's including various substance use and listed here, which I'm not going to read through. And the data here, it shows the 4 groups of the LGBT plus population are above county average and the overall, and they're reporting a problem due to substance use at up to 2 times the rates of non-LGBTQ plus adults. Now moving towards the neighborhood and the social facts. And SHAPE is very, very great in terms of gather data. It's for many, many reasons, but one of it is we always keep a balance of how much data we ask for each of the health domain. With that guiding principle, we be pretend and make sure we have enough space to ask a neighborhood social determinants. And just for that, because in a broader term, health access could be, social determinant, many other, but just for the neighborhood and social facts, we be able to ask and the amount of the question, just like the overall health, just like the mental health, just like the risk behavior on that part. What I'm going to show is a couple of the measurements or the indicator from this domain. The first is the ever experienced violence. And the data shows every single LGBTQ plus population reporting higher rates than county average. And about half of them, and for many groups, non-binary, transgender, and the bisexual and the pansexual queer is reporting ever experienced violence. Overall, they reporting a rate and for ever experiencing violence at up to 3 times rates of non-LGBTQ plus population. Next indicator is the economic distress. It's a construct, it's a measurement, and which we measure from 3 groups of the insecurity: food insecurity, housing insecurity, and transportation insecurity. Within each of these insecurity, we have 1 or 2 actual question gather data to measure that. Anyone experienced any insecurity in this domain, in this construct or the area we ask, are classified as experience economic distress. Here's the data. And the 46% experienced economic distress. And so do the rate is higher among other LGBTQ plus population. Overall, they experience economic distress at up to 3 times rates of non-LGBTQ plus population. And also you see the rates varies across these groups. The next measurements, it's a little bit heavy. It's the discrimination question. It's due to SOGI. And the thing I'm going to mention is the SHAPE ask a lot social and kind of in terms of broad term of the public health is very proactive, and we monitor discrimination experience since 1998, and over time, we make improve on this question and achieving data equity every day as we go. And the community helped us do the right thing, and we do consult different community on that. In SHAPE 2022, there's several questions on discrimination we included, which details together data on discrimination due to SOGI, due to race, ethnicity, religion, immigration status, and the discrimination in various life setting situations, like seeking job, getting house, and getting health care. What I'm going to show here is the one measurements is frequent discrimination due to SOGI. And this is the question how we ask, how we define, which you can read later on. So what's heavy about this is and you see county overall rates here is 4%. Every single indicator which I showed before today, it's the 10% the lowest, but here it's 4%. And it's 4%, although in the ideal world we're living in should be 0%. But this is 4% to start with. But you can see the striking differences between LGBTQ adult population, how they report discrimination. We labeled here as not ever experienced discrimination. It's a frequent discrimination which they report, and have that situation they experienced, feel unaccepted, and every week or at least 12, the monthly on that. So the striking differences is the thing. It's this what these data slides show, and if we calculate, it will be at least 8 times as high as the other group, or up to 20%, on that. So just be modest in summarize these data. It's the LGBTQ adults reporting frequent discrimination due to SOGI at more than 10 times the rate of non-LGBTQ plus population. And we just finished the review of the 13 indicators we selected among many indicators gathered from SHAPE. And we compared to non-adult LGBTQ adults, and we learned LGBTQ adults in Hennepin County reporting much higher rates of the poor health. It's among 13 and 12 showing all significant finding, and only unmet medical health is across board, it's all high. 2/3 of population experience unmet medical care needs. And specifically LGBTQ adults, LGBTQ plus adults report up to 2 times as high as in in the overall health and health condition measurements, up to 5 times as high as in mental health and well-being measurements, and up to 3 times as high as health access, measurements, up to 3 times as high as substance use, and at least up to 8 times as high as for neighborhood facts and social determinants. And these kind of conclude another key points from when we compare the data among all adults between these two groups. We also learned health disparity varies across 5 LGBTQ plus population as well. Now, just as Admiral Levine highlighted in her opening remark, collecting population level LGBTQ data is the key to meeting the needs of LGBTQ plus people. We need the data to tell where disparity exists. And the SHAPE data experience here is gathering population data of LGBT allow us to learn where disparity exists between LGBTQ plus population and the non-LGBTQ plus. and identify and also allow us to identify the magnitude of disparity. It's not equal across LGBTQ plus population. So that's what we want to share about all adults population. Next, moving on to the LGBTQ plus and the health and the BIPOC population. Knowing the BIPOC is not a term we really like to use, but I will explain why. And to choosing to present data for BIPOC is as we when we present data and when we have data out, and often we heard is that we really from our working group, and we have several meetings, and our working group really help us to gear what the best thing to provide and to using today's time to present data. And the repeated we heard is that we really want to understand intersectionality of the data, which means, being LGBTQ plus, what is about, how about the data for the race, ethnicity specific data? How about for the older adults? And we had several groups repeatedly mention to us, as well as over time we hear from the community. And we only have time today choosing one, and we just say, let's take a look for the data for the race and the ethnicity. This is how we gather data for shape for the race and ethnicity. It's very long, but allow multiple choice. We list 6 major race category. And just pay a little bit attention is we do have subgroups, and for 2 race group to check from. One is for Black and African American, and the second is for Asian and the Asian American. We do have 3 spaces for people written text, and which we take seriously. We coding these data and process those texts seriously as well. So SHAPE do using very proactive efforts to reach and the population, and we be able, this table showing there is many groups we can reporting data on, and these are the category for every indicator we're reporting data in our data book, as well as these we have 2 online sources which I'm going to describe later. So this is for each of these groups. We have some decent sample size to report data to. And but still, if we say, and if we don't looking at the non-Hispanic white and combine the ratio ethnic groups are 2281, and our task here is trying to describe data for the LGBTQ plus population, and look, and so as of now, we just for this group in a quick way to references, we're using BIPOC for these 4 race group. It's Asian and Asian America, Black, African America, Hispanic, Latino, American Indian, and refer as a BIPOC population, we have 2081. And now looking at the LGBTQ counts we'll have, we have 3 questions, and looking at the far right column and the LGBTQ counts, and for a total from all survey responded, we have 1,004. Can be say they mentioned check any LGBTQ plus population. And if we don't including white, which is non-Hispanic white in here, I labeled it as a non-BIPOC, it's 705. We have 270, check the any. So in terms of the reporting and the detailing these issue is we're using among BIPOC adults, although we know BIPOC is not the way we want to combine all, and it's not the preferred term we use, but just for a short phrase referring to that group. And we compare LGBTQ plus versus non-LGBTQ plus. First indicate is the it's the poor or fair health. And in this case, the comparison between these two groups is not statistically significant. We also provide a county-wide estimate for BIPOC adults is 23%. 23%. So for the interest of time and for the 13 indicator which we just showed among all adults, I'm going to show these results which between these two groups are statistically significant, not saying the other is not important. So I'm going to just skip that part. And also for the all health indicator, we, kind of, it's the same, the definition is the same. I'm not going to show in the slides how we define that. So activity limitation, we're going to skip that, it's non-statistically different. And here, showing the high risk depression. Between LGBTQ plus population as non-LGBTQ plus population, and there is a statistic significant between these two. Why BIPOC is 15% and the LGBTQ plus population reporting 24%. 24%. And overall, it's the among BIPOC adults, LGBTQ adults reporting high risk of depression at nearly 2 times the rate of non-BIPOC population. And just adding a little bit kind of more layer, I'm only show on this, the later I'm not going to show that way, is that when we compare data among BIPOC population, we need to think about how they compare to the county overall adults or the non-BIPOC population. If I showing all the data slides, is too busy on that. And on here, you will see the all adults is 10%. It's 10%. And these rates, when we talk about the all adults data, it's all presented over there. So in these slides, when we put that way, it really tells these 24% of the higher is among among all adults, they are higher. But this is in addition based on being BIPOC, it's 15%, they are higher than all adults. So the data showing here 24% when we talk about, it really reflects the intersectionality of being BIPOC and the being LGBT plus population. It's the dual identities here. And so which means being not only single one fact, by the two facts being there, it's really introduce additional risk, being there exposed to additional risk and for reporting poor health. In this case, is the high risk of depression. So from now on, for the rest of the slides, and when I talk about, and I will make statement, these rates reflect intersectionality of being BIPOC and being LGBT. It's all I have going through those kind of analysis, just making that results to you. But we are not going to have time to cover details of all on that. So the frequent, the high risk of the anxiety is significant. LGBTQ plus being BIPOC is reporting higher than their counterpart who are not. And these rates also reflect the intersectionality of being by that two factor, two identity. The next is the frequent, it's not. Sorry, I pressed a little bit too fast. So frequent social isolation is the same. Intersectionality is also significant. And moving on towards, I will skip the health access variable. And here is the marijuana using. And 32% of LGBTQ plus population and reporting current marijuana use, which is significantly higher than the non-LGBTQ plus population. And such a rate is based on 15% being BIPOC to start with, average, and being BIPOC is also significantly higher rates than the non-BIPOC. It's also intersectionality, kind of the effect is over there. Next is the problem due to substance using, and similarly, LGBTQ plus population is higher than that. This is the rates, is BIPOC population. Next is the experience, ever experienced the violence where among BIPOC population, LGBTQ plus population, and the reporting ever experienced the violence at the higher rates than non-LGBTQ adults. And similarly for the frequent discrimination and the strike, even within this is striking difference between these two, and this is also reflect the intersectionality of being by multi identity. So just quickly going through this a little bit, I'm sorry for being a little bit kind of the very, very fast to showing these data, but in summary, among BIPOC adults, LGBTQ plus population reporting high rates of poor health as compared to non-LGBTQ plus, and such a differences are significant for each of these three domains. And I'm not going to read through of these. I will jump to the overall summary of the health disparity experienced by LGBTQ plus population who are BIPOC reflects the intersectionality of being BIPOC as well as being LGBTQ plus population. Key takeaway for all the data presented as now is LGBTQ adults reporting higher rates across health domain as compared to non-LGBTQ plus population. And the health disparity varies across LGBTQ plus population or subgroups. And looking at the data with intersectionality shows the health varies across LGBTQ plus population and the subpopulation. Today's case, we're using the BIPOC population. And achieving health equity demands health equity, data equity, and the local health department can advance SOGI data collection. And using Emerald Levine's opening remarks here is the spirit of the community is what we need now and more than ever. And we're finishing with, and we can do better job and must do better job, and with your help, and we will do better by Emerald Levine. So probably we will, let me see. We will probably, I will just quickly show you two online sources. One is the dashboard. If you type in www.hennepin.us/shape, it will lead to the website. You will have two available data, kind of the reporting source. One is dashboard. The other is the data book. And we have physical data book here as well, which is online for that each reporting by race, ethnicity. And then now we will open for the question.
Thank you so much, Komal and May. And also thank you to them and their SHAPE team for all of the data analysis that went into this presentation. So we will open up for questions. We have about 6 minutes for questions. There are two folks here with microphones, so if you could please make sure you speak right into the microphone so folks online can hear the questions. And then for those of you who have joined online, please type your question into the Q&A box, and I'll do my best to monitor those and ask those questions. Any questions?
Test. Oh, there we go. Thank you. Good morning. Patrick Ingram, Red Door Clinic. And I first want to say thank you for the fabulous presentation and for all those involved in the project. I think it's really important to recognize that one thing I appreciate is that you centered race as a part of this discussion, because I think that's extremely important. I'm curious, and I recognize that our commish and other distinguished speakers weren't here for the entirety of this presentation. And I think it's really important for them to know about this information that's being shared. And so I'm curious, how are elected and appointed leaders obtain and use this information to support the creation and advancement of holistic health in our communities, especially as we continue to see increases in HIV diagnoses among Latinx and Black, gay, bisexual, and men who have sex with men, mental limited housing, economic disparities, mental health, substance use disorder, as well as just overall what the presentation shared was a decrease in happiness among LGBTQ plus people of color. And I'm just curious in terms of how they obtain this data and how does that help in their decision making and making the policy decisions that they make.
You heard the question. So if I can summarize, and please correct me if I'm wrong, but the question is really focused on how can commissioners use the data to make decisions around things like disparities. Is that right?
Thank you for that question, Patrick. So one thing, one example that I can share that I'm aware of is the disparity reduction domain work. They rely a lot on our data to advance some of their work. So that's one thing that's coming to mind. Do we have any other examples that we could share? And we constantly share our shape data and other data with commissioners on a regular basis to make their decisions. Sure. 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 Yes. Thank you. We'll definitely do that.
Other questions?
I want to repeat the thank you. That's an immense amount of data, and it's welcoming that you go ahead and look at the SOGI data. This is so critical. I'm wondering about being able to look at lesbian health separate from gay health, and how you define lesbians when you look at having gay and lesbian together. Are you able to discern information specifically about lesbians?
In certain way, we can. It won't be perfect, as we kind of that we get when we using, if you remember, like the survey question did not ask a gay and lesbian separately, but we do have a gender question to proxy that part. As I say, I do acknowledge it's not perfect with the existing how we gather, but now you said it, we heard it. So, so when we kind of because we are so fortunate for Hennepin County Board, it's a continuous support we have continued support to do this survey and continue to gather data. And everything you say, we listen carefully, we document, and we'll inform our data improvement. As we say, we need advanced data equity every day. And that's what the spirit we carry on. It will continue that way, and we will make notes. And it will be But as of now, if you want to do, we can do approximate and any kind of data, because by separate the gay and the lesbian is not available at the current public facing data reporting. And we can run data for you, or you can access data and run data by yourself.
I think we have time for one more question. I'm not seeing anything in the Q&A box unless I'm missing something. But is there another question?
Yes. Hi, I'm Chase, he, him pronouns. So I was looking at the data regarding men, women, non-binary, and then trans was a separate category. So my question is, are trans people considered a part of the man-woman category? Like if you're a trans man, would that be included in male? Or were they expected to answer a separate question? And would that kind of skew the data regarding if you're a trans person trying to pick which kind of question to answer?
And thank you for the question. And Kamal went through with how we gather these data. I think from second or third time we do shape, transgender is a separate question. We never cross with the gender question to define transgender. Wherever transgender is a separate entity as they identify themselves. And is that answer to your question or any? We can always talk when we kind of during the break or the other time. Yeah.
Well, again, thank you, Kamal and May. We'll now take a break for about 10 minutes. So if you could please come back at 10:32. And we'll continue with two things. Oren Roy will be presenting the youth LGBTQ plus data from the Minnesota Student Survey, Hennepin County data. And then we'll also hear more about the Biden-Harris administration SOGI data action plan. So please come back at 10:32. All right. Well, I'm very pleased to introduce Oren Roy, who will now present Hennepin County data from the 2022 Minnesota Student Survey. Oren Roy, who prefers they, them pronouns, is a senior planning analyst with both the Ryan White program and the health evaluation and assessment team at Hennepin County Public Health. Oren's work with the health education and assessment team centers on updating sexual orientation and gender identity data collection and reporting recommendations to improve LGBTQ plus data equity. Their work with the Ryan White program focuses on advancing health equity for people living with HIV, particularly around housing. They are passionate about health equity, harm reduction, public health law, and LGBTQ plus health. Please welcome Oren Roy.
Hello and good morning, everyone. Thank you, Jonathan, for the introduction, and thank you all for being here today to talk about LGBTQ plus health in Hennepin County. Today, I'm really excited to talk to you all about data and key health indicators for LGBTQ plus youth in Hennepin County from the Minnesota Student Survey. So for today's presentation, I'm going to first talk about a little bit of a background and overview for the Minnesota Student Survey for those of you who are not as familiar with it. I'll also specifically talk about how sexual orientation and gender identity, or SOGI data, was collected in the 2022 Minnesota Student Survey. Then I'll be going into the counts of LGBTQ plus youth in Hennepin County before spending the bulk of the presentation talking about key health indicators for LGBTQ plus health. And like was done with the SHAPE presentation earlier, I'll be spotlighting a couple of key health indicators from all that were included in the Minnesota Student Survey. I'll finish everything up with a conclusion, and like with the previous presentation, there will be time at the end for questions, and the slides and recordings will be available to you afterwards as well. Before diving into talking about the Minnesota Student Survey, I wanted to first contextualize what I'm about to present and some of the recent challenges that we've seen around LGBTQ plus youth in this country. As Dr. Tura had mentioned in the beginning of this event, data don't exist in a vacuum, and what I'm about to share today is really framed by the challenges that LGBTQ plus youth are experiencing in this country, specifically the recent increase in homophobia and transphobia against LGBTQ plus youth on both structural and interpersonal levels. In this context, collecting data like this and sharing data like this is really important because it helps tell this story, and we can really see how some of these obstacles and political challenges around LGBTQ plus youth are reflected in the data that I'm about to share. At the same time, obstacles are only part of the story, and resilience and joy and positive change are also really possible and exist for LGBTQ plus youth. I know a lot of us in this room here today are really in the driver's seat and strategically positioned to create change for LGBTQ plus youth. So with sharing this data, I'm excited to not only, tell the story about some of the challenges that LGBTQ plus youth are experiencing, but also provide a roadmap for where we might want to go and what kind of interventions we might want to have to better support and protect LGBTQ plus youth. So now I'll talk a little bit about the background for the Minnesota Student Survey. So the Minnesota Student Survey is one of the longest running youth surveys in the nation. It's been conducted every 3 years since 1989 and is the primary source of youth data for the state, county, and local level in Minnesota. It's also a collaboration between local schools and the 4 state agencies you can see listed here. MSS is really important because it helps provide insight into the experiences of youth in Minnesota. And because of its comprehensiveness and how frequently it's conducted, it's also the only consistent source of statewide data on on youth, especially for subpopulations like LGBTQ plus youth or youth of color. This makes the Minnesota Student Survey a really helpful tool for schools, communities, and other agencies to be able to design interventions and really understand the health and well-being of youth in the state. So in contrast to SHAPE, which is a survey, which is a sample, sorry. The Minnesota Student Survey is a census-like survey. So all schools are invited to participate, and it is voluntary to school districts and also anonymous. The Minnesota Student Survey includes students in grades 5, 8, 9, and 11. There are also 3 different versions of the survey depending on students' age, with 5th graders getting the most simplified version of the survey, 11th graders receiving the most complete, the full survey, and with 8th and 9th graders getting something that's a little bit in between. It also has been administered online in recent years. So as I was talking about, the Minnesota Student Survey is a really comprehensive survey that collects data across all of these different domains for youth. And you can see, all the different types of experiences that it collects data on. In the interest of time today, we're only going to be spotlighting a couple of these health domains, not going to be going into all of them, but all of these domains are available, or data on all of these domains is available to you, and we'll have some information at the end as well on how to request that data if it's of interest to you. Now I want to talk a little bit about the number of students in Hennepin County who participated in the Minnesota Student Survey in 2022. So on a statewide level, there were actually over 135,000 students who participated in the survey. And in Hennepin County, we had over 26,000 students who generously lent their time and their data for the survey. You can also see this as the percentage of enrollment. As I mentioned, the Minnesota Student Survey is a census survey. So there were over 60% of students in Hennepin County enrolled who participated in the survey, which makes it, again, a really comprehensive database to draw from. And you can also see some of the breakdown by enrollment, some of the breakdown by grade here as well. So now I want to finish up in the background section by talking a little bit about how specifically the Minnesota Student Survey collected SOGI data. So this is the question that the Minnesota Student Survey had about gender identity. And this question was only asked to students in grades 8 and older. Fifth graders were not asked a comprehensive gender identity question. So you can see here there were multiple gender identity options for students to choose from, and students could also choose more than one gender identity as well. For the purposes of our presentation today, we're categorizing students as gender expansive if they selected an identity that was not strictly cisgender. So everybody who's highlighted in red here are students who are categorizing in the category of gender expansive. Turning to sexual orientation, this again question was only asked to students in grades 8 and older, and there were multiple sexual orientation identities that students could choose from. What was I going to say here? Oh yeah, unlike the gender identity question, this was a single choice response, so students could choose any one of these options from this list. And for the purposes of our presentation, we're categorizing students as LGBTQ if they selected a sexual orientation outside of strictly straight or heterosexual. You can also see here that there is no specific question in the Minnesota Student Survey about whether or not students identify as LGBTQ. So for the purposes of our presentation, we are counting students as LGBTQ in that category if they identified as gender expansive or with one of these sexual orientations listed here. So with that background, I now want to talk a little bit about the amount of data that we have, and specifically the counts of LGBTQ+ youth in Hennepin County. So this slide shows the number of students who identify as LGBTQ as per our definition. You can see that there were over 5,000 students in the Minnesota Student Survey who fit within the category of LGBTQ, with a pretty even distribution among those who identify as LGBTQ+ and cisgender, and those who identify as transgender, non-binary, or an additional identity. You'll also notice here that the denominator here is a little bit over 18,000. This is a little bit smaller than the 26,000 that I shared previously, and that's because none of the fifth grade students were asked the SOGI questions, so they weren't included in the denominator for looking at the number of students who are LGBTQ. So that's why that's 18,000. However, I do want to point out here that only about 2.4% of students in grades 8, 9, and 11 left the SOGI questions blank, which means that we have really comprehensive data on the amount of the number of students who identify as LGBTQ, and that students are also pretty comfortable answering these questions as well and talking about their identities and sharing their identities with us. We also, on the right-hand side, you can see this data represented graphically, with almost 30% of students in Hennepin County identifying as LGBTQ, which is a pretty large percentage, but also pretty on par with national level data and trends on the amount of young people who identify as LGBTQ. As I shared previously, we are collecting, or we have the privilege of getting a lot of data about specific orientations and identities here as well. So I wanted to take some time to share some data about the specific sexual orientations and gender identities that the Minnesota Student Survey collects, and really break down this big category of LGBTQ a little bit further. This slide shows the number of students, the counts for the number of students who identified as LGBTQ, and you can see that there are some identities that were more identified with than others. A lot of students identified as bisexual and questioning, but there were also still a large number of students who identified as queer or asexual. So this really shows how important it is to include a vast variety of sexual orientation options in surveys, because there are a lot of students who identify with some of these categories. Turning to the counts of gender expansive students, again, you can see what that breakdown looks like here. The majority, or about a third of students who identified as gender expansive actually identified with 2 or more identities, which again, really shows how important it is to allow students to pick from multiple options. And there was a pretty even split among the number of students who identified with some of the other gender identities listed here. So with that, I now want to, with that background, and I want to jump into talking a little bit about the actual data itself and talking about key health indicators for LGBTQ plus youth. So as I had mentioned in the beginning of this presentation, the Minnesota Student Survey is a really big survey and it asks about a lot of different health domains, and it's a really comprehensive survey. While we have all of that data and it is accessible to you if you would like, again, there'll be information at the end for how to request specific data. For the purposes of this presentation, I wanted to spotlight a couple of key health domains that were identified by our planning work group as some of the most important and pressing domains for LGBTQ plus youth specifically. So first, I'm going to be starting by talking about data on mental health. This was identified as one of the most important health indicators for LGBTQ plus youth, and it really provides context for some of the issues that LGBTQ plus youth are dealing with. At the same time, we know that mental health and other health indicators don't exist in a bubble, and a lot of times the environments that students are in can really influence their health indicators. So with that, I want to then move into talking about some of the environment and experiences that surround LGBTQ plus youth by talking specifically about experiences with bullying and discrimination. We also know that students' health experiences and the environments that they're in can drive some of the health behaviors that they engage in. And one of the health behaviors that I want to spotlight here today is talking about substance use. And then finally, as was done with the SHAPE presentation, we know that this category of LGBTQ plus youth is really broad and includes a lot of different people with a lot of different experiences and backgrounds. So I want to take some time at the end to highlight some of the diversity within LGBTQ plus youth, and also to really showcase the diversity of the data that we have that is, again, accessible to you. Again, this is a really small piece of the data that we've picked out, and you can always request more data if you'd like. And as Jonathan had mentioned in the beginning of this forum, I know that some of this data can be really challenging to look at and really close to some of your own experiences and experiences of the people that you work with. So please do whatever you need to do throughout this presentation to take care of yourself as we move through talking about this data together. So now I want to jump into starting by talking about mental health, again, because it's identified as one of the most pressing issues for LGBTQ plus youth. And I'll be sharing data on a continuum of mental health experiences, starting from anxiety and depression and moving into more serious mental health indicators like self-harm and suicide. So the first slide that I have here is reporting on high risk of depression. And this graph shows the percentage of students who reported high risk of depression, first starting by sexual orientation. Again, the Minnesota Student Survey, because it asks about all of these identity categories and we have pretty robust numbers for a lot of these categories, we're able to really show the amount of data that we have. Unlike SHAPE, this was a census survey, so we're not doing any statistical tests with these data, so you can kind of take these measures as is. And all of the LGBTQ or LGBTQ plus students are going to be the darker bars on this graph and on subsequent graphs as well. With the orange line down here showing the overall rate for all students in Hennepin County. I also do have some slides on the measures for like high risk of depression and some of the other health indicators I'll share. So specifically like showing the types of questions that were included in the Minnesota Student Survey and how we've got some of these measures for like depression, anxiety, and some other measures that I'll show. But for the purposes of this presentation, in the interest of time, I'll not show those specific like ways of how we got to capturing some of these measures, but they will be available to you afterwards if you're interested in looking through for learning a little bit more about how we got these data. But talking about this data specifically, you can see that there are a lot of differences among how students who identify with different sexual orientations report high risk of depression, with some groups reporting a little bit higher rates than others, especially when compared to straight or heterosexual students. Moving into sharing the same outcome, high risk of depression, same indicator, high risk of depression. This graph shows it by gender identity. You can see that the cisgender non-LGBTQ plus students and cisgender LGBTQ Plus students are some of the lighter bars, with the gender expansive students representing the darker bars in this chart. And again, we see a lot of those same, we see that there are differences among how students report high risk of depression based on the types of gender identities that they identify with. Those two slides had a lot of data, and that can be really helpful, but also really overwhelming to look at times. So for the remaining indicators that I'll be sharing, I'm going to be condensing all of that data into 3 bars so that the message is a little bit clearer, and so that we can really emphasize some of the key differences that we're seeing for LGBTQ plus youth. So this is again reporting high risk, this is looking at high risk of depression, but here instead of reporting on all of those sexual orientations and gender identities that I had shared previously, I'm condensing these data into looking at straight and cisgender students, so the non-LGBTQ plus students on the left hand in the lightest color, LGBTQ plus cisgender students in the middle as the blue color, and then gender expansive students on the right hand side in the darkest color, to again really condense some of the data that we have. At the same time, though, we still do have all of that data that I shared previously about looking at specific sexual orientations and gender identities. So if that is something that is of interest to you and your work, you're always more than welcome to request that data to really break down some of the indicators that I'll be sharing into those specific categories as well. But over here, the main message that I wanted to share with looking at high risk of depression is that we see that LGBTQ plus youth report high risk of depression at over twice the rate of non-LGBTQ plus youth, with LGBTQ plus cisgender students reporting over twice the rate compared to straight cisgender students, and gender expansive students reporting almost 3 times the rate compared to straight cisgender students. Moving on to another health indicator under mental health, we have high risk of anxiety. And here we can see similar trends with LGBTQ plus youth as a whole reporting high risk of anxiety at over twice the rate of non-LGBTQ plus youth. You can see that LGBTQ plus cisgender youth are reporting over twice the rate compared to straight cisgender youth, and gender expansive youth are reporting almost 3 times the rate of high risk of anxiety compared to their straight cisgender peers. Moving down the continuum of mental health, we also have data on self-harm in the last year. And here we can see that LGBTQ plus youth overall report self-harm in the past year at up to 4 times the rate of non-LGBTQ plus youth, with LGBTQ plus cisgender youth reporting almost 3 times the rate compared to their non-LGBTQ plus peers, and gender expansive youth reporting over 3 times, up to 4 times the rate of self-harm in the last year compared to straight cisgender youth. Finally, the last indicator that I want to share under mental health is suicide ideation or attempts ever. And we can see similarly troubling trends here in the percentage of students who reported suicide ideation or attempts in the last year, overall, with LGBTQ plus cisgender youth reporting almost 3 times the rate of suicide ideation or attempts in the past year, and gender expansive youth reporting up to 4 times the rate of suicide ideation or attempts in the last year, with over half of gender expansive youth reporting suicide ideation or attempts. So again, this really highlights the burden of mental health for LGBTQ plus youth in Hennepin County. So that data was talking a little bit about mental health to really emphasize, the experiences of LGBTQ plus youth around mental health, and specifically the high burden that LGBTQ plus youth have with regards to mental health. Now I want to move into talking a little bit about the surrounding factors around what we see with LGBTQ plus youth. With the Minnesota Student Survey, because of its survey design, there's no possible conclusions or things that we can say about causation and things like that. But we can, say that a lot of times we know that mental health doesn't exist in a vacuum, and things that surround the experiences of youth can have an impact on their mental health. And one of those things that I want to talk about here today now is bullying and discrimination. And again, talking about different aspects of this and breaking down this domain a little bit further. So the first measure that I want to share is harassment because of sexual orientation or gender identity. And with this graph here, you can show that as a whole, you can see that as a whole, LGBTQ plus youth report being harassed specifically because of their sexual orientation or gender identity at up to 3 times the rate of non-LGBTQ plus youth, with LGBTQ plus cisgender youth reporting over twice the rate compared to their straight cisgender peers, and gender expansive youth reporting up to 3 times the rate of discrimination because of sexual orientation or gender identity in the last month compared to their straight cisgender peers. Pulling back a little bit, we can also look at bullying overall, bullying and discrimination, again in the past month, including things like being pushed, shoved, hit, or threatened with physical harm. So looking a little bit further beyond just discrimination because of sexual orientation or gender identity. Here you can see that the rates are unfortunately elevated for all students compared to SOGI related discrimination specifically, with students overall reporting higher rates of bullying in the last month. But you can still see that there are disparities for LGBTQ plus youth, with LGBTQ plus youth reporting being bullied in the last month at up to 1.5 times the rate of non-LGBTQ plus youth, with again, gender expansive youth reporting more compared to LGBTQ plus cisgender youth, and LGBTQ plus youth as an overall group, over half of them are reporting being bullied in the last month. We know that students are also living in, or people in general are also living in an increasingly digital world. And unfortunately, students' experiences with bullying extend beyond the classroom and also trickle into their digital worlds. So here we also have data about cyberbullying in the last month, specifically through texting or social media. And you can see here that LGBTQ plus youth report being cyberbullied at up to twice the rate of non-LGBTQ plus youth, with again, gender expansive youth reporting being cyberbullied at higher rates than LGBTQ plus cisgender youth in the last month. Finally, the last piece of data that I want to share in this domain is feeling unsafe. So this measure looks at students feeling unsafe going to and from school, in their neighborhoods, and in their homes. And you can see here that LGBTQ plus youth reporting feeling unsafe at up to 3 times the rate of non-LGBTQ plus youth, with LGBTQ plus cisgender youth reporting feeling unsafe at almost twice the rate, and gender expansive youth reporting feeling unsafe at up to 3 times the rate of non-LGBTQ plus youth. And I think what this slide and what this whole section has really showed is that violence can often be inescapable for a lot of LGBTQ plus youth, existing not just in their schools, but also in their communities, in their homes, and in the online spaces that they are in. And again, while there's nothing that we can say about causation or things like that, we know that we can hypothesize that some of these experiences with violence and mental health may be driving some of the behaviors that LGBTQ plus youth engage in. And one specific behavior that I'll not be spotlighting is alcohol, tobacco, and other drug use. So the first measure that we have here is cigarette use in the last month. And you can see here that overall cigarette use is pretty low for students, which is really great and really reflective of a lot of the work that we've been doing as public health professionals around tobacco. But there are still disparities for LGBTQ plus youth, with LGBTQ plus cisgender youth reporting cigarette use in the last month at up to twice the rate of compared to straight cisgender youth, and gender expansive youth reporting cigarette use at up to 4 times the rate of straight cisgender youth. We also know that for young people, traditional cigarette use is not as popular as vaping or e-cigarette use, and that's a growing concern for young people. So here we also have data specifically on vaping and e-cigarette use in the past month. And you can see similar disparities here as well, with LGBTQ plus youth reporting vape or e-cigarette use in the past month at more than twice the rate of straight cisgender youth. Looking at alcohol use, we again see similar trends, with the LGBTQ plus students reporting alcohol use at almost 2 times the rate of non-LGBTQ plus youth in the past month, with gender expansive youth, again, reporting slightly higher rates of alcohol use compared to LGBTQ plus cisgender youth. We also know that marijuana is is a drug that's increasing in popularity among young people. So we also have some data here specifically about marijuana use in the past month. And we can again see those similar trends with LGBTQ plus youth reporting marijuana use in the past month at more than twice the rate of non-LGBTQ plus youth. This is also one of the measures where LGBTQ plus cisgender youth actually report slightly higher rates compared to gender expansive youth. For all the data that we've seen so far, the trend has been a little bit reversed with gender expansive youth having the higher health burden. But here we can see that that's reversed a little bit. But still, overall, the disparity holds that LGBTQ plus youth are reporting marijuana use at up to twice the rate, or more than twice the rate of non-LGBTQ plus youth. And finally, the last piece of information that I want to share related to alcohol, tobacco, and other drug use is the use of illicit drugs or misuse of prescription drugs in the last year. And we can again see very similar disparities with LGBTQ plus youth as a whole reporting illicit drug use or the misuse of prescription drugs in the last year at more than at up to twice the rate of non-LGBTQ plus youth, with gender expansive youth, again, reporting higher use of illicit drugs or misuse of prescription drugs in the last year compared to LGBTQ plus cisgender youth. So that was a lot of data that I just shared with you all about key health indicators for LGBTQ plus youth. So I now wanted to take an opportunity to summarize a little bit of what we've seen before diving into some of the subgroup analysis. So compared to non-LGBTQ plus youth, we're seeing that LGBTQ plus as a whole are reporting 3 times higher rates of high risk of depression or anxiety. Moving down the continuum of mental health, this goes up to 4 times higher rates for self-harm and suicide ideation. So looking at some of those more serious and concerning mental health indicators that we have. Looking at bullying and discrimination, we're seeing that LGBTQ plus youth are reporting 2 times higher rates of bullying and discrimination compared to non-LGBTQ plus youth, and 3 times higher rates of feeling unsafe compared to non-LGBTQ plus youth. And then finally, when it comes to alcohol, tobacco, and other drug use, LGBTQ plus youth are reporting 2 times higher rates of substance use compared to their non-LGBTQ plus peers. So with that summary, I now want to take some time to talk about specific subgroups. So again, because of the size and scope of the Minnesota Student Survey, it really presents an opportunity for specific analysis for specific subgroups. So we know that, again, LGBTQ plus youth is a really big population with a lot of different experiences. So now I'm going to take some time to break down this large category by looking at specific subgroups and experiences related to race, ethnicity, childhood experiences, adverse childhood experiences, as well as protective factors to, again, showcase the diversity of LGBTQ plus youth, as well as the diversity of the data that we have. Going into this section, I just want to specifically highlight that I'm only going to be focusing on one health indicator, and that's high risk of depression because of the interest of time, and only highlighting some of the specific subgroups that we have. The Minnesota Student Survey has a lot of data, and if there's any specific subgroups or other health indicators that you're interested in looking at, there will be that information at the end for how to request that data. So I just wanted to give that caveat and some grounding before moving into this portion of the presentation. So the first subgroup that I want to talk about is race ethnicity. And you can see here with high risk of depression as the indicator that LGBTQ plus youth are reporting high risk of depression at different rates for different race ethnicities. This data is only focused on LGBTQ plus youth. So I'm not sharing data on non-LGBTQ plus youth here. And the bars are again associated with different race ethnicities. And the blue line across is showing the overall rate for specifically LGBTQ plus students. You'll also see here that there are 2 race ethnicities who were included in the Minnesota Student Survey, but whose data that I'm not sharing here, and that's American Indian and Alaska Native students, as well as Middle Eastern North African students, and that's because there were small counts for these groups for LGBTQ plus students. So to protect the data privacy for these students and to avoid further stigmatizing these groups, these data are not going to be shared in this presentation, but we do have that data in general for other health indicators. So if those are populations that you work with that you're interested interested in seeing, you can request that data. Looking at high risk of depression, you'll see that this is one indicator where there actually isn't a lot of variability across race ethnicity for LGBTQ plus youth, with most LGBTQ plus youth reporting pretty similar rates of high risk of depression across these race ethnicities. However, we can also look at specific ethnic groups as well, since we know that Hennepin County is a really diverse, has a really diverse population with a lot of different ethnic groups. And the Minnesota Student Survey does have and collect data on some of these specific ethnic groups. So this is, again, looking at high risk of depression as the indicator. And you can see that LGBTQ plus youth report different rates of high risk of depression based on the different ethnic groups that they identify with. You can see, for example, here that Chinese and Indian students report lower rates of high risk of depression compared to West African or African American students. So race ethnicity is one way to slice your data. You can also look at other experiences that can be affecting the experiences of LGBTQ plus youth. So here we have some data on LGBTQ plus youth depending on the number of adverse childhood experiences, or ACEs, that they report. So ACEs, for those of you who may not be familiar, are defined as potentially traumatic experiences that occur in childhood. They include things like living with someone who uses illicit drugs, being physically hurt by parents or guardians, or having parents or guardians who have ever been to jail or prison. The Minnesota Student Survey collected data on a total of 8 established ACEs. And we kind of grouped that into 3 big categories here. To report on the percentage of students who report on high risk of depression, of LGBTQ plus students who report on high risk of depression, by the number of adverse childhood experiences that they also said that they have experience with. So you can really see here that when it comes to the burden of mental health, there is a sizable difference between which LGBTQ plus students are really holding that burden, depending on some of their adverse childhood experiences. So you can see that students who report having no childhood, LGBTQ plus students who report having no ACEs are reporting the lowest rates of high risk of depression, with students who have 1 to 3 ACEs or 4 to 8 ACEs reporting a sizably higher rate of high risk of depression compared to LGBTQ plus students with no ACEs. So you can really see how having some of these childhood experiences can impact the types of mental health challenges that LGBTQ plus youth are experiencing. So I've spent a lot of time talking about kind of more negative outcomes, or more of the obstacles that LGBTQ plus youth are dealing with. So I now wanted to take a little bit of time to talk about some protective factors and some things that can be positive and supportive for you. So just for some orientation for what we're looking at, this graph shows the percentage of students, again, with high risk of depression by different protective factors that they have. So protective factors are things that can be, as the name suggests, protective against some of the more negative health experiences that we're reporting here. Specifically with this measure, it would be high risk of depression. And again, while the Minnesota Student Survey doesn't allow us to make any conclusions about causations or things like that, what we can see here is that LGBTQ plus students who have protective factors, having that protective factor is associated with a lower rate of high risk of depression compared to those students who don't report having those protective factors. So 4 specific protective factors that we've spotlighted here, you can see what they are at the bottom. And you can see that LGBTQ plus students who feel empowered, who have positive self-identity, who feel socially competent, and who have connections to caring adults are reporting high risk of depression at lower rates compared to those students who don't. So I think what this really shows is an opportunity for interventions to really support LGBTQ plus youth, and that there are things that are associated with lower negative mental health outcomes for LGBTQ plus youth. And I also want to note here with this slide that there are a bunch of other protective factors that the Minnesota Student Survey collected. Just in the interest of time, I'll not be sharing that data, but again, it is accessible to you if there are specific protective factors that you're interested in looking at more. So with that, I now want to wrap everything up with a conclusion to really summarize what we've looked at today. So with our key takeaways, we can see that looking across all of the health indicators that I shared, that they really vary across LGBTQ plus youth and also across the different subpopulations within this broader category. So as I had shared in the very beginning of this presentation, you saw that even, across sexual orientations and gender identities, that there are differences among in the types of health indicators that students are reporting, and that also for specific subpopulations, like looking across race, ethnicity, or looking across ACEs, that there are differences in health indicators for LGBTQ plus youth. Even though there are, these nuances across these like subgroups and subpopulations, we can see as a whole that LGBTQ plus youth are reporting higher rates of mental health issues, bullying, and drug use compared to their non-LGBTQ plus peers, and that this is really disproportionately affecting gender expansive youth who are reporting worse health indicators as a whole compared to their cisgender LGBTQ plus peers. While this data does highlight a lot of challenges and obstacles that LGBTQ plus youth are facing, I think it also really showcases the resiliency of LGBTQ plus youth in light of some of these challenges that they're experiencing. And the data and the disparities that we can see shows that this is a really systemic problem for LGBTQ plus youth, the higher burden of some of these health indicators that we're seeing, and that this data really supports taking actions around LGBTQ plus health to protect them and to ensure that they have better health outcomes than the ones, or health indicators than the ones that we're seeing here today. So with that, I wanted to now wrap up the presentation by sharing some of the resources that we have. So the Minnesota Student Survey is a public, all of the data from the Minnesota Student Survey is publicly accessible. So you can see some of those links here for being able to access some of the reports and PDF tables that are available on the Minnesota Department of Education website. And there is also that form to request additional data. You can use that form or also reach out to the SHAPE team whose email was shared in earlier in the earlier part of this data forum. So with that, I now wanted to open up the floor for any questions.
Thank you, Oren. I did miss some earlier questions, so I'm going to also ask these from the chat box. So thank you for your patience for those of you who are online. And these are more general data questions. How can the general public support this work?
I will speak for the SHAPE project itself. And I have to acknowledge it's like the Hennepin County just own big for our community because the residents generally contribute their time to contribute to the survey. Responding survey, when you receive a survey for us is a big support. And on the other end, support could be let us know how data is useful for your community, let us know, as well as say, we need data. We know you have data and we need data and contact us to make us better to serve you, better to utilize data. I don't know what else to.
Thank you, May. Another question, how do I access disaggregated data?
So thank you for the question. I think we do have, like May briefly shared on our SHAPE webpage, we do have data that you can access on our Power BI dashboard. You can also access data through our data book, but we welcome any questions or any data requests that you might have that we may be able to fulfill as well from our team. So definitely reach out to us anytime with any questions or any data requests that you have.
More questions from folks here and online on the MSS data or any data that we've talked about today? If you could also please say who you are and where you're from, that would be great.
Hi, my name is Kathy Root. I work for Hennepin County Public Health Promotion and Schools with Wellbeing. You have trend data that you would take the MSS data from 2019 through 2022. We know in 2022 was coming off COVID. We had a less participation, but any observations that you might have if things are getting worse or better?
Yeah, that's a great question. So the question was about trend data for the Minnesota Student Survey. So as you had alluded to, the Minnesota Student Survey only started to collect really robust data on sexual orientation and gender identity in 2019. So there unfortunately isn't a lot of like a long range to look at in terms of time for some of these trends, unlike for SHAPE, which has been collecting SOGI data since its onset. For the purposes of this data form, we really limited it to looking at just for Minnesota Student Survey 2022. We do have the 2019 data as well. So if that is something that you're interested in, you can do that data request to take a look at it. But I also do not know that some of the measures and indicators have changed over time, as well as how the Minnesota Student Survey collected SOGI data in 2019 compared to 2022. So that does kind of restrict the amount of trend comparison that we're able to do. But in the slide deck, it was one of the hidden slides that'll be available in the PDF report that'll be sent out afterwards. There is data, or I did pull out the questions of how SOGI data was collected in 2019 if you're interested in taking a look at that. So I hope that answers the question.
Yes, please.
Hi, my name is Chandler, he, him, his pronouns. I work at Family Tree Clinic, and I have a question following up on what Chase was asking about how SOGI data is collected in the SHAPE survey compared to MSS, and this is for you, Lauren, but I've historically preferred questions that ask transgender as a separate question so that transgender people don't have to don't have to report their gender identity as different from cisgender peers who have the same gender identity. So like a transgender woman doesn't have to click something other than woman when asked about the gender identity, but I haven't seen it the way that it was on the 2022 MSS with the, boy/man and then like cisgender boy/man/ and then transgender. So I'm curious just like what thought went into that. But y'all came to that decision, and if you've got any feedback about like that making more or less sense for young people specifically, and like, yeah, just how those decisions were made.
Yeah, that's a great question that I could speak to. So the Minnesota Student Survey is not designed or administered by Hennepin County. So we actually don't design the SOGI data questions directly for the Minnesota Student Survey. So that's why it's a little bit different for SHAPE, because it's run entirely by Hennepin County, we have a lot of ownership and flexibility over how we're asking questions and how we're able to collect data. So for the Minnesota Student Survey, that's kind of how it was asked. I know that there are like data working groups and collaborations that exist between all the state agencies, including Hennepin County. And I know that our conversations for future Minnesota Student Surveys, how some of those questions want to be asked. But with SHAPE, we actually noticed some of those things too. And if I could speak a little bit on that. One of the reasons why we asked the question about transgender identity separately was to avoid like stigmatizing trans men or trans women by having them like select a separate choice outside of just man and women. So that's one of our, that was some of our like reasoning behind why we structured SHAPE the way that we did. And both of these surveys are like a work in progress, as Komal and May had talked about. We're always updating the way that we ask questions based on what the community is saying and based on changing definitions and identities and things like that. But with SHAPE, we have a little bit more flexibility than with the Minnesota Student Survey coming from Hennepin County. But we are, I think, always happy to hear what people have to say around data equity and LGBTQ plus data equity specifically. So yeah, thank you for the question.
I'll take another question from the chat here, and I have some unsuccessful experience in data requests. The staff requested a Zoom meeting to talk about the request, then ghosted. Can you give me some tips?
For the, it's listed as anonymous here, but I'm apologize for that because it should not be happen. But we do noticing like due to recent ownership of the shape, who shape. If you talk about shape data, it's kind of the shape website have a generic address. That ownership have a recent kind of a bit change, and we have been working on with IT to get that fixed. It has not, but when you through, and we do know a couple of people, and through the people they know and notify us directly, normally we respond very quickly. In general, the intention is response as quick as possible. But if we do have that kind of, we are not, our team did not get the direct notice due to something change. We're still working with our IT, to fix that issue, and I apologize for that.
And certainly with the material from today and that we'll send all of you, there are ways to get connected to us more directly. So please use those avenues. And we do want you to use these data, and we want more folks to use these data. So please, please reach out to us. Here's another question from the chat. This was an excellent presentation. How was the report used to reduce the disparities identified at schools? And if there are folks here who work in the schools, maybe you can answer that question. And raise your hand and we can hand you the microphone.
The comprehensive mental health system. There's a National Center for School Mental Health that has an assessment called the SHAPE assessment that can take to look at their strengths, gaps. You have what's called a tiered system support. So at tier 1 is for all students. Things in there might be like working on school climate, restorative practices, social emotional learning components, better health literacy, at the scope of health curriculum. And at tier 2 is more for like group services and early interventions. And then there's tier 3, which is mental health supports in the building, which might be direct working with like a school-based mental health therapist. There's a whole area of Hennepin County that coordinates having school therapists. So those are some of the supports that can be provided. And I guess some policy around LGBT, like bathroom activities and that. It's all a work in progress.
Thank you. Any other questions in the room? Yes.
Hi, Kevin Sitter, mostly retired person in HIV. For the school data, I'm very pleased that the ACEs included, but I'm wondering if there's a specific question about the support students receive in their primary household.
Yeah, that's a good question. So the question was like if there's a question about the support students receive in their primary household. So yeah, there are questions that kind of get around the topic of support that students have. Some of those protective factors that I was sharing are some of those examples. So we have like questions about connections to parents or caregivers specifically, connections to other relatives, connections to caring adults in communities, and school and things like that. There are also questions about whether or not students were able to access specific like mental health support or any other types of healthcare that they need. Just in the interest of time, we didn't present all of those data, but there are data about like, and they would fall within the protective factors category of the kinds of support that students are receiving, as well as the kinds of like enrichment that they're getting from participating in school activities and things like that, that kind of fit within that umbrella of support around some of these ACEs that students experience. So great question.
Another question from folks joining online. How can public health respond to these disparities more directly at a structural level? Well, I guess it's a very excellent question and maybe a little bit harder to answer. You know, I can speak a little bit to our world in the HIV world. You know, one of the things I like about the question is it's a systemic level question. And for those of us who work in public health, I think we're closer to being able to change systems. I know I'm working with the HIV system of care that we do work very much hand in hand with our state partners in helping to build a more culturally responsive system of care for folks with HIV. We work in ways to do that. We work in a number of ways to do that through you know, things for that come all the way from contracting, how we contract for services, different funding streams, how we prioritize specific populations in our work. So I can speak a little bit from the HIV. We have a long way to go. I think many of you know, just looking at these data, we know the system is not working well for a lot of LGBTQ folks, both adults and youth, and also Black, Indigenous, and people of color. And then, of course, when the intersection of those comes into play, it makes the system becomes even more difficult and less responsive. You know, we do have a lot of work to do, and I think there are some good things that are happening, and these data are really helping to drive some of that work. And if there are other folks in public health and want to address that question, please speak up. And yes, Patrick.
Thanks so much. So yeah, Patrick Ingram with Red Door. I think to Jonathan's point, coming from the sexual health and HIV as well as advocacy space, I think one of the things that I've taken away over this time is being and hiring folks that have skin in the game. I think that's so critical because at the end of the day, a lot of times what I've seen coming from the South to Minnesota is that we're at the table of decision making, but we lack individuals who represent the populations that are underserved. So we must, as a group, collectively work together with community, and we must make sure that we're engaging young people and people of color to really be effective in the work. Kind of circling back to what I was talking about in the beginning when I spoke, and I'm going to keep it real brief, but we also have to have our elected and appointed leadership a part of the conversation, proactively engaged. We cannot systemically address this system that is patriarchal and white supremacist if we don't have all partners at the table.
Thank you, Patrick. There will be some time for more discussion, so we are going to move on, and of course you can contact us directly with additional questions today. I'm very excited to welcome Adrienne Shanker from the U.S. Health and Human Services Assistant Secretary for Health's office, who has been leading the Biden and Harris administration's SOGI Data Action Plan. Adrienne Shanker, who goes by he, him pronouns, is a Health and Human Services Senior Advisor on LGBTQI+ health equity. In that role, he leads the LGBTQI+ policy portfolio for the department and coordinates the HHS LGBTQI+ policy coordinating committee. Before joining the Biden-Harris administration, Adrienne led the LGBTQI+ community centers in Allentown, Pennsylvania, and Marin County, California, and served as commissioner on the Pennsylvania Human Relations Commission, the state civil rights enforcement agency, a post he was appointed to by Governor Tom Wolf and confirmed by the Pennsylvania State Senate. He also previously served as a member of the Presidential Advisory Council on HIV/AIDS. Adrienne earned his BA cum laude in political science and religion studies from Muhlenberg College and earned a graduate certificate in LGBT health policy and practice from the George Washington University. Adrienne has published numerous articles and has edited 2 anthologies on LGBTQI+ health policy, Bodies and Barriers, Queer Activists on Health and Crisis and Care, Queer Activist Responses to a Global Pandemic. Please welcome Adrienne Shanker.
Thank you so much. It's so great to be with you today. And as was mentioned, I'm Adrienne Shanker. I use he, him pronouns. and I have the honor of serving in the Biden-Harris administration at the U.S. Department of Health and Human Services as Senior Advisor on LGBTQI+ health equity. I serve under the leadership of Secretary Becerra and Admiral Levine, two incredible leaders who are champions for equity for LGBTQI+ people. And as part of that work, we are working diligently every day to advance data equity for LGBTQI+ people when it comes to our data for our health and well-being. President Biden signed an executive order in June 2021 that required every federal department to create a SOGI data action plan, a sexual orientation, gender identity data action plan. This followed the publication of the Federal Evidence Agenda on LGBTQI+ equality, which was written by career level, not political statisticians across the federal government who developed an agenda that's research informed, data informed, and based on how we're going to build the evidence base when it comes to equity for LGBTQI+ people across government. At HHS, what this looks like is making a SOGI data determination on every single one of our data instruments, and we have hundreds of data instruments across HHS. So last June, we finalized our SOGI data action plan, which is currently being implemented. And what this looks like is that every one of our HHS divisions, and by divisions, I mean like CDC, NIH, FDA, et cetera, they're all asked to review every federal survey and form that they have that asks demographic questions on it and make a determination on how and when they will add SOGI measures into those data instruments. We've already had some early victories here with the addition of SOGI measures into, for example, the HIV, STI, and MPOX case reports at CDC, and into the enrollment applications for healthcare.gov and Medicare Part C and D at Centers for Medicare and Medicaid Services, and to the Medicare Expenditure Panel Survey at the Agency for Healthcare Research and Quality, and at SAMHSA adding gender identity into the National Survey on Drug Use and Health, as well as the DAWN, the Drug and Alcohol Warning Network, a nationwide surveillance system used to measure hospital admittance based on substance misuse. At the Administration for Community Living, they've added in SOGI measures to the Alzheimer's and Dementia Data Reporting Tool and to the State Health Insurance Program, or SHIP, Enrollment Assistance Program. So those are just some examples. We've actually done much more, and this work is intended to make SOGI data the norm in public health and human services. We like to say internally that we measure what we treasure, and we can't fix what we can't measure. So we can't fix the health disparities that exist in our society if we don't have good data to demonstrate what those health disparities are. We can't address enrollment disparities in terms of insurance coverage if we don't have clear data on what those disparities are. And in terms of human services, the same is true. We need to understand access to care challenges, both for access to healthcare and access to human services. So this work includes our human service components of HHS too. It's really important as we're advancing this work that we ask SOGI questions in the most evidence-based ways. So it's not just a process to say we want to add in sexual orientation and gender identity. It's what that means when we say that we're doing that. And so we are strong supporters of the NASEM report that and we've modified it to meet certain specific needs. For example, Indian Health Service, when they added in SOGI into their patient records throughout all of Indian Health Service, that looked a little bit different than what the Medicare enrollment forms look like, because it's a different population. So for example, within Indian Health Service, Two-Spirit was a field that was added in, even though that's not in the NASEM recommendation specifically, but because its services directly provided to American Indian and Alaska Native populations, Two-Spirit was added in. And as we're doing this work, we're also testing both field and cognitive testing of questions to ensure that they're well understood and that they will work for measuring sexual and gender minority populations across our communities. This work is incredibly important to us, and it also impacts outside of government. So for example, Office of National Coordinator for Health IT at HHS proposed and the public comment period has ended for US CDI 5, US Core Data for Interoperability version 5, to require not only the collection, but also the transfer of SOGI data between electronic health records. And that would be, once finalized, that would be required by January 2026. So this is really important. Also, some of our surveillance surveys are done in partnerships with state and local governments. Certainly the data collection is often done with external partners to the federal government. So there's a need for this work to happen beyond the federal government as well, for private sector as well as state and local governments to consider doing the same thing that we're doing by evaluating where it makes sense to incorporate SOGI data measures into forms and surveys. And ideally, if we ask questions based on evidence-based practices, we can end up comparing the data as well. And that can be particularly useful as we're trying to address disparities in certain regions of the country, for example, or between certain health challenges. So that's a little bit of a peek at what we're doing. We are moving rapidly to advance SOGI data efforts and data equity broadly. The department's also engaged in efforts around race and ethnicity data. This is a huge area of importance to the Secretary and to the White House, and it's very important to us at HHS. So I'm happy to take some questions, if there are any, about our work to advance data equity and SOGI data in particular within U.S. Department of Health and Human Services. I should also have just said, though, that what we're doing at HHS is at HHS, the same process is happening at other federal agencies as well. So while I only spoke to HHS because that's where I sit, the executive order required every department to do this process. And so it looks slightly different at different departments, but this is work that is happening in other federal agencies as well.
Thank you so much, Adrian. Are there any questions for Adrian about the administration's SOGI Data Action Plan? Yes, Kevin.
Thank you so much. This is government at its best. I so appreciate your work. I'm wondering about the security confidentiality of SOGI data, especially for those maybe trying to enter the country, green cards, citizenship, military.
Thank you for that question. In general, well, first off, for almost all, for pretty much every data system, demographics are optional for the person filling it out. So even where we add in SOGI measures, it's not optional for the survey administrator to include it. It's not optional for the person asking the question to ask it. It is optional for the person answering to decide whether they want to share it. And we will, in certain instances, remind people how we use the data, that we're not trying to pry into people's personal lives. What we're trying to do is to measure disparities in access to care challenges so that we can fix those challenges, right? And also, to your point, there are some data instruments where we're deciding not to move forward with SOGI data measures because we don't want to create increased risk for certain spaces. So there have been and will continue to be decisions that in certain data instruments, the risk outweighs the benefit. Most of the time, we believe the benefit outweighs the risk, but there are some circumstances where that's not the case. So we are taking extra care to make those determinations. We don't ever want SOGI data to be used in a harmful way. We're trying to use it to improve care, not to cause harm. And our first priority here is do no harm. So now you also asked about data confidentiality. So broadly, for federal data, the data is very secure. Most of the time it's anonymized. So we don't even have the person's individual level data. We only have aggregate level data. And so that is the easiest answer there. There are certain data systems that have enhanced security to it. And then we're talking also about like general forms people fill out. So it really depends on the data instrument, but there are protections in place regarding personally identifiable information. And that's why most of the time, all demographic information is only provided in the aggregate. It's a great question.
Yeah, thank you. Any other questions for Adrian while he's with us? I'm going to just check online here, see if we have any other questions. think we do. Building off the question of data privacy and confidentiality, what ways can people who choose to disclose LGBTQ plus identities be protected while we are seeing many states implementing harmful legislation, especially for trans individuals?
That's a great question as well. And we are certainly aware of the challenges in this area. I work on LGBTQI plus policy for HHS broadly, so data equity is one component of that work. It's a really important component, but we're very aware of the restrictions on gender-affirming care in many states, as well as other health challenges such as HIV criminalization laws. So we're very aware of this. And that's, again, why we are being diligent about which data instruments to add SOGI measures into, who will have access to the data, and how the data will be utilized. So it is a careful process, not an impulsive process, as we're making this determination for each data system. We typically don't share individual level data back to states or other partners. There are some circumstances where that might be the case, and in those cases we would be more likely to determine not to add SOGI measures in. But for the most part, that's not what happens. We usually share aggregate level data. So it might be like at the state level, this is what we're seeing in terms of disparities. And so that's typically how that would be handled. But yes, those considerations are very much being worked into decision-making around where and when to add in SOGI measures, and also how to add in SOGI measures. Like what types of, the way we word the question also has an impact. Sometimes we're asking about current gender identity as opposed to transgender status, for example. So we're typically asking basically 3 questions: a 2-step gender identity question and a sexual orientation question. And actually, the 2-step gender identity question is sometimes easier than the sexual orientation question. But the sexual orientation question is really important to us. When we ask the 2-step gender identity question, we're asking sex assigned at birth and current gender identity, and then we are able to infer transgender status rather than simply asking if someone's transgender, which we are not typically doing at this point.
Thank you. There's another question for Adrian. Yes.
Good morning. Thank you so much. I'm curious, you talked about, it sounds like, an executive order in regards to deploying a SOGI data. So could you talk a little bit about what that process was like or been like for HHS, any difficulties? Because change is sometimes and most often difficult, especially within government. So I'm curious how that process has been, what has been basically roadblocks or areas for opportunities and learning that you're taking away from this this implementation process.
Yeah, so I mean, thank you for that question. The presence of an executive order prioritizing data equity for LGBTQI plus people has been really significant. It certainly opens the door to the conversation and allows for prioritization when we have many other really important things happening across government in terms of data policy. So the executive order certainly raised the issue up and opened the doors to allow us to have the necessary conversations within government to move the issue forward. In terms of challenges and roadblocks, I would honestly say the biggest challenge we have is that SOGI measures are newer in the scope of data science, and there's more work needed to cognitively test and validate questions. Especially as we're talking about certain parts of the LGBTQI plus population. So for example, we have the NASEM recommendations, and we have, an OMB recommendation for statistical surveys, but we don't necessarily have data standards for administrative forms, for example. We also don't have field or cognitively tested questions for LGBTQI plus youth, for intersex people, for two-spirit people, for asexual people. We don't have field and cognitively tested questions for LGBTQI plus older adults. So there are certain data instruments where we might want to have a specifically tested question. We don't have tested questions in languages other than English, actually. And so our SOGI data action plan does call for trying to also build that evidence base, and we are doing some of that work, but there's a role both external as well as within government to do that work. Like any researcher that wants to test questions can do so and can do a write-up on it in an academic journal, and that helps build the evidence base on understanding the cognitive testing of some of these questions. The languages other than English piece is really critical in SOGI data spaces right now. And if there's something I might encourage external researchers to consider, as well as state and local governments, is like, if there are surveys being run in multiple languages, including field testing on some of those other languages to make sure people understand the questions is really important, and then actually doing a write-up on it to make sure that it helps build the evidence base. That can't be overstated how important that is, because right now we have instances where we have not been able to add in SOGI measures because we don't have the validated questions yet. And the same would happen at the state level, frankly. You would probably get the same responses in some of those same circumstances. So we need to build the evidence base at the same time as we're trying to expand the work, and we're doing it as we're doing them simultaneously. We're literally building the car as we're driving it. But I think that's the greatest roadblock right now. There's one additional roadblock, which is there's still a need to educate people in both the data science world and also in the general public about why we're asking these questions. So, I still hear frequently, like, why would you ask someone's sexual orientation on like a healthcare enrollment form? And the answer is because we want to know if the LGBTQI community is underrepresented, equally represented, or overrepresented among insured people. And if there's underrepresentation, we want to look at addressing it. And if we have overrepresentation, then we want to see why we still have health disparities if we have overrepresented insurance coverage. Like, there are really clear data utility needs of SOGI measurement in the public health space and in the healthcare space. And we don't know that without asking, but we still have a lot of education to do to help people understand why we would add these questions in the first place. And I don't think that would be different at the state level or community level.
Thank you, Adrian. Do you have time for one more question if there's
I have
one?
time. Yes, I do. Thank you.
Are there any more questions for Adrian? I don't see any more questions in the chat. So thank you so much, Adrian. We very much appreciate the work that the administration is doing around your SOGI Data Action Plan. And I just want to say that, when we think of the action that we can take, we're part of this as well. We can make a difference in these data by making sure that our public health agencies are implementing the SOGI Data Action Plan. For me in the HIV world, I'm very much interested in seeing SOGI data in our HIV epidemiological reports from the state, also that we produce in the county to make sure that our surveillance teams here are incorporating SOGI data collection in their processes. And so the more we ask, the more likely we'll be able to see those data. So we do have a big part in that.
And I would just say that, like, we've added in SOGI into, for example, HIV case reporting for new infections. We have not added it into like the Ryan White system. HUD has not added it into the HOPWA system. So there is still like work to do to advance data equity, even within spaces people presume it will have already happened. And we will continue to do that work. Our SOGI Data Action Plan at HHS, as well as the plan at HUD and National Science Foundation, have all been made public. You can Google them and find them. We also invite you to let us know if there are HHS data systems, surveys, or federal forms that HHS manages where we're not adding SOGI right now, but you think we should. And if you tell us how you use that data, that's really helpful for us to hear, and we can try to see if we can prioritize addressing it. So the organizers of today's event, you're free to share my email with anyone who's attending who requests it. And thank you very much for inviting me to join you today. And more importantly, thank you for your commitment to data equity for LGBTQI+ people. This work is so important, and we're really thrilled that you have an interest in it in Hennepin County as well.
Thank you so much, Adrian. And along with Adrian's contact information, we'll also send you out the link to the administration's data